اهلا بيكم. انا هاني نعيم، استشاري السكر والغدد الصماء. بكلمكم النهارده من بوخارست. بحضر هنا مؤتمر النيورودياب، مؤتمر الجمعيه الاوروبيه لالتهاب الاعصاب السكري، ويسعدني ويشرفني ان يبقى معايا استاذي بروفيسور بروس بيركنز من كندا. Will you please introduce yourself, Professor?
Sure thing. I'm Bruce Perkins. I'm an adult endocrinologist and professor and clinician scientist at the University of Toronto. I direct a diabetes center called the Leadership Sinai Center for Diabetes that has complex clinical care, but also research. And my research focuses mostly in type 1 diabetes.
Okay, so let's pick up from where you left with our last episode.
Yeah, we were talking about fat.
Fat with type 1 diabetes.
Yes.
So, as a resident, as a student, as a specialist even, okay, I had never seen a single patient who had type 1 diabetes who wasn't, I wouldn't say obese, who wasn't overweight.
Yeah.
Then, suddenly, it's becoming like 50% of my type 1 patients are considerably obese.
Yeah.
What do you have to say about that?
Sure. So the first thing is that it used to be that if someone's diagnosed with diabetes, the way we would figure out whether it's type 1 versus type 2 would include whether they're overweight and obese. We'd think more likely type 2, and if they're not, then more likely type 1. But now the general population on average is heavier, so we can't follow that simple rule as much anymore. So that's the first thing. Secondly is when you are diagnosed with type 1 diabetes and then you're on insulin therapy, if you achieve better control, you are at higher risk of gaining weight. And in fact, we've learned in our long-term studies of large groups of people with type 1 diabetes that it's about, as you said, 50, even more, 60% at least have overweight or obesity. So in part, this is because the overall population has gains weight, but also within type 1 diabetes, having better
control,
blood sugar control on average can lead to more weight gain over time. That's one of the side effects of insulin therapy. That's why we're trying to give insulin therapy better, and I think we're achieving it, being able to deliver insulin better without that weight gain, with newer insulins and insulin pump and hybrid closed loop. These can help. But for sure, there's a lot more overweight and obesity. Like, for example, in this study that we were just talking about in the last episode called DCCT, the Diabetes Control and Complications Trial, we followed about 1,400 people with type 1 for over 40 years. 60% of them are overweight or obese. And we're seeing that there's a fair amount of liver fat. We're able to test for liver fat with these special tests. And the condition, it used to be called NASH. You just said NASH a moment ago. We call it MASLD. So it means, it's a terrible, for those who named it out there, but it stands for Metabolic Dysfunction Associated Steatotic Liver Disease. And basically what it means...
Fatty liver.
But, it's not just the fat. Once there's fat accumulating, it can then lead to inflammation and then scarring in the liver that can progress and cause liver disease and increase actually the risk for liver cancer as well. So we're now starting to understand that people with type 1 diabetes actually have quite a bit of liver fat. And we're now, we are applying to renew in these next years to look deeper into the liver. We're going to be doing this MRI thing. It's called, I won't tell you what it's called, but it's a special way of seeing the consequences of liver fat through an imaging technique called MRI, magnetic resonance imaging.
Elastography, spectroscopy.
Yeah, so it's this thing called photon density fat fraction, PDFF.
Which is, let's spare the technicalities, but we have other simpler methods. Like FibroScan.
So that's what we've done already. FibroScan, and in fact, even before FibroScan, there's a simple score that we get from someone's age. The FIB4 score.
It's very simple.
It's very simple, but we're okay, I shouldn't say this out loud and reveal, but it may, in type 1 diabetes, it may not be as good at detecting fatty liver disease. We're starting to figure that out now.
No, I believe people with diabetes generally should have much lower cutoff values than the general population.
Maybe
we,
you're right.
we should have like a higher index for suspicion at a much lower score.
Yep. Yeah, you may be right. So we might be able to answer that in type 1 diabetes. We just haven't yet. We're studying that now in that DCCT edict study. But the thing is, like, what do you do? So, if someone, it's much more common in type 2. We think it's much more common in type 2 diabetes. What we do there is really encourage diet and exercise. Like, how do we get fatty liver? Well, one way is by over-consuming food. Like, I don't know if this is a thing in Egypt. I doubt it. I hope not. But like in North America, there's this thing called foie gras in France. Foie gras.
Believe me, we have other alternatives which are worse.
I see. But they're basically force-fed ducks or force-fed geese. And after the force feeding, their liver is harvested, and it's this beautiful, buttery, fatty liver.
It's because like you get the duck and you just keep
Force
feeding it
with grain.
Okay, now.
So it's a similar idea. So actually, diet and exercise can really help reduce liver fat as long as it's done early before the scarring happens. And then in type 2 diabetes, it turns out that a bunch of the standard drugs used for blood sugar control can be very helpful. So there's those weight loss drugs with diabetes control, the so-called
the
GLP-1.
Mounjaro, this type of stuff. Okay.
Those can be really helpful. There's these types of pills that help us pee out sugar.
Oh, you mean that's GLT2s? Okay.
Exactly.
Okay.
And then there's actually now a new treatment. I don't know, it's not available in Canada. It's available in the US. It's specifically for the scarring stage.
Resmetirom, I mean?
Yes, resmetirom, which is, it's weird. It involves a very interesting mechanism. Which has to do with thyroid hormone.
It's severely high thyroxine levels inside the liver cells, which makes it burn out all the fat inside.
Basically, that's a good summary.
Okay.
That's well said. Anyway, let's say someone has type 1 diabetes and develops fatty liver. We have diet and exercise, but then those other drugs are used for type 2. They're not really approved for type 1. Resmetirom is not exactly available yet, but that's the more severe liver cases. These are people who are being handled by liver specialists or at least what we call gastroenterologists. But we're going to have to figure out in type 1, if this fatty liver is really a problem, it's going to be a motivation to study those type 2 diabetes drugs more in type 1. Like you said, the Ozempic, Mounjaro type drugs, which are being studied.
And they
more.
work. And we have proof they work.
Exactly.
In type 2.
And the weird thing is the way these drugs are sold, they have a name for the same drug that applies to diabetes.
And another name for weight losing.
Non-type 2 diabetes, which really can include type 1.
But it's ridiculous. Okay, like
it's confusing. I agree with you there. It is confusing.
Okay, it's call it whatever. Let's call it John. Okay, if it's semaglutide, then I call it John today, and I call it Ozempic tomorrow, and I call it Wegovy after tomorrow, and then the day after I call it Nokia or whatever. Okay, it's still semaglutide.
It's still the same drug, but the idea is that the name for people should be associated with the condition they're treating, and Ozempic is for treating type 2 diabetes, blood sugar, and weight control, whereas Wegovy, the exact same drug, different name, is meant for people without type 2 diabetes who are struggling with overweight, obesity, and generally some complications.
If I give a person with type 2 diabetes Wegovy, will it say, I won't control your blood sugar because I have a different name?
Yeah, exactly. Yeah, you're right. It is. We agree it's a bit weird and frustrating. But it's weird and frustrating because it was a requirement of regulators, and regulators, their job in the government is to help protect people. So there are good reasons for having different names, but it's still confusing.
I hope the reasons are good, but I don't understand them. Okay, but it's not my place. Well, anyway, so that's concerning the liver. What about obstructive sleep apnea? Okay, and what about the fat around the heart, the epicardial adipose tissue?
Yeah. Okay, so if we're talking about in type 1 diabetes, this is all in planning for our big type 1 diabetes study called the DCCT edict, which I think I just mentioned a moment ago in this podcast, I think. So we're doing imaging to look at tissue in the chest that includes the epicardial fat, which is fat around the heart. We think it's a particularly toxic fat, like it can irritate blood vessels in the heart. We're trying to understand that better, but we really don't yet in type 1. I mean, interestingly, we have studied epicardial fats before in DCCT edict in a more limited group, but we're now expanding it. Let's just say more fat inside the body
Generally is bad.
is generally bad. As it turns out, from a health or metabolic health perspective, having more fat on the outside of the body is in some ways can be good, meaning as long as we have the ability to store that fat.
Basically, what you're talking, to make this clear, we can have fat, like belly fat, in the outside of the belly, not on the inside of the belly.
Correct.
Okay, so this is
And around
just,
organs in the
just
inside.
under skin and not around organs inside the body.
Right.
Okay, is probably much, much, much better than not having any fat outside, but having fat on the inside around the liver, the kidneys, the heart. Okay, this is what you're saying, which is what's called visceral fat.
Yeah, and now they're a little associated, right? If we carry more weight overall, we probably have more visceral or internal fat.
Both go hand in hand, more
But
or
it
less.
seems like some people
Lucky ones.
are not able to store fat as well on the outside.
Lucky one. No, these are the
And-
unlucky ones.
They're unlucky,
The unlucky
and their fat goes primarily to the inside, and we kind of know that's a bad situation. So I think the best situation is to have less fat overall, but certainly the internal fat and organs is the more dangerous fat, it seems.
Okay, so if I have fat around the heart, it makes this heart not pump properly or not fill properly, more or less, and it's bad for the arteries and the muscle of the heart. Am I correct?
Yeah, maybe. I don't know for sure, to be honest. The first part you said that the fat kind of makes it tough for the heart to pump. I'm not exactly sure that's
I'm
true.
talking about the heart failure with preserved ejection fraction. I'm
Yeah.
trying to say it.
Yeah,
that's
I'm not
okay.
exactly sure.
Okay,
that-
not the pumping, it's the filling. It
Yeah.
makes it stiffer.
Yeah, you're right. You're right, because there's different pockets of fat around the heart. So yeah, you may be right, but to me that fat is associated with like inflammation and it can affect arteries. And you're right, heart. Yeah, I think let's
Okay.
just say you're right.
So, and we know that fat in the liver causes what's used to be called NASH and now is called muscle D, which is fatty liver disease,
Right.
whatever you call it. Okay.
Right.
We know that fat, we're talking about that fat which is not supposed to be present and is present in the tongue and around the throat area, causes obstructive sleep apnea.
Yep.
Okay. Which has a very long list of things which will follow. Okay.
Right.
And what about fat in the kidneys?
Yeah.
Fatty kidney disease.
Yeah. Well, it happens. There is kidney fat, but personally, I don't know much about it. I know a lot about the kidneys, but I'm not sure that it's been a major.
It's still
issue.
not being properly studied yet. It still hasn't. We'll find it gain favor in a few years' time, and suddenly everyone's talking about it, just like what happened with the liver.
Well, if that's the case, I'll remember this conversation. I'll remember this conversation. Yeah, it's interesting. I don't think the kidney capsule and stuff. It may not be a major place that fat is deposited, but there is fat. You're right.
Okay, you have other things like focal segmental glomerulosclerosis, and these are like badly understood diseases, let's say.
Yeah,
Okay,
yeah.
like
Yeah,
no one
they
really
would-
understands it.
That's
Okay,
correct, yeah.
which is strongly correlated with having extra fat. Okay, and we still don't know what happens, and it hasn't been like a major interest for research till now, up to my knowledge.
Yeah, I mean, there's even like minimal change disease. It's a specific kidney disease that is associated with certain risk factors like obesity, but kind of rare. Yeah.
Yeah. So
So what's the point to this whole discussion?
what's the point? Okay, it's easiest if you don't gain it in the first place. If you don't gain the fat in the first place.
Yep.
And if you do gain it, it's a very tough job to lose it, especially without certified medications and you have type 1 diabetes.
Yep,
Okay.
that's true.
We hope that these medications will be properly studied and approved for its use in type 1, in my opinion.
Yep.
Probably they will be. I personally can't see anything horrible about them in type 1.
Yeah,
but
exactly. They don't have. There's some other classes of drugs that have been explored that have, more concerning side effects. This doesn't. It's the standard side effects that everyone can get, which is mostly
Okay.
nausea and vomiting when you start it, and are titrating doses.
Nothing really. Not commonly, nothing really. We don't see serious adverse effects.
Yeah, exactly. You're right.
Okay. Then, so at the end, we talked about that type 1 can, against our formal training ages ago, okay, type 1 can have increased weight, okay, which is totally against everything we learned a long time ago.
Correct.
Okay. They can get all complications of obesity just like type 2 and just like anyone else.
Yep.
Okay. And this can be reversed if you lose the weight. What about bariatric surgery?
Yeah. So bariatric surgery is, if we're talking about this fatty liver disease, definitely helps with it.
It
But
helps with
kind of-
obstructive sleep apnea.
and with sleep, yeah, for sure. I mean, it's a major source of weight loss. But we're at a particular point in time now where there's been the development of these drugs, the drugs that started with Ozempic, Wegovy, and now Mounjaro,
And there's a lot more about to
Yeah.
come out.
so there's a new agent. These, it's a bit tricky to describe, but there are these, basically they're gut hormones. They're made in our gut that are involved in blood sugar regulation, but they're also involved in feedback to the brain around how full we are, and they can sort of suppress appetite, make us feel more satiated, less hungry. And so the first level of them dealt with one of three hormones, and then there's one that deals with a second hormone, and now there's a third drug. This is an agent called retatrutide that actually is a triple agonist for three of these hormones. And on average, in people with obesity, it has the type of weight loss that we see with bariatric surgery. Like
Even
on
stronger
average.
than bariatric surgery.
Yeah, so I mean, it means that the relevance of bariatric surgery is decreasing, or maybe decrease. I think it's decreasing.
But-
We've got better drugs. Now, remember, these drugs, they don't work in isolation. They work when someone's made a commitment to weight loss.
Yes.
They've committed to diet and physical activity. They've made that a routine part. Because even though these drugs suppress appetites a bit, you can undo it by just eating more food. In fact, you can undo bariatric surgery. Like bariatric surgery, it's tougher to eat solid foods, but you can have high-calorie liquids.
Yes.
that Still, you can undo
Chocolate.
it. So anyone undertaking any of these things, surgery, medications, they have to be kind of made a dedicated decision. Like let's say I'm trying to lose weight and I decide, well, what I want to do is I realize that maybe I'm just making this up, but maybe I'm someone who eats a lot of their calories in the evening before going to sleep. And what I want to do is reduce that. I want to have dinner, and then I don't want to eat food until it's breakfast. I'm working hard at, trying to occupy my mind and myself so that I'm not thinking about food in the evening. Maybe I'm not watching television commercials that make me eat. I'm working hard on it. And if I take one of these medications, it has that effect on suppressing appetite. It makes it more possible that I'll achieve my goal by not having those extra calories in the evening. But if I'm not thinking about that at all, even if I'm taking this medication, I can still undo it. But if you're doing them together,
not Hercules at the end of the day. Like anything we do has its limits.
Yeah, that's true. And actually, any one thing is never quite good enough. It has to be a combination of things: diet, exercise, and the smart use of these medications. And the same applies to surgery. A lot of people have failed bariatric surgery. They've had some initial weight loss and then later weight gain.
It again.
So it really has to be part of a whole philosophical approach around diet, exercise, and these other interventions.
Well, this is the end of our time for this episode. I really can't thank you enough, Professor, and I hope to see you again in Cairo.
Oh, that would be amazing.
I'd love to have you in Cairo.
I've never been to Egypt.
Really? Come to Egypt. You really love it.
I know I would love it.
And besides, you really love our food.
I already do. I already do. That's a fact.
Okay. Thanks a lot, Professor. And let's hope to see you next year with a few new episodes with our podcast.
Perfect.
Thank you, sir.
All right, thank you. And again, congratulations on all your work and your advocacy work. And it's
Thanks,
amazing.
sir. Thank you. Thank you so much.